Good morning, beautiful people. Welcome back to the second hour of LoveBabz, LoveTalk. I am Babz Rawls-Ivy, and this morning we are going to get a lesson on how to get screened and take care of ourselves because March is Colorectal Cancer Prevention Month. And I have the good fortune of having Dr. Xavier Llor, who is the director of the Smilow Cancer Genetics and Prevention Program, Associate Director for Cancer Screening, Community Engagement, and Health Equity, and medical director of the Colorectal Cancer Prevention Program at Yale University and Smilow Cancer Hospital. Welcome, doctor. Unmute yourself. How you doing?
Thank you very much. So glad to be here.
Oh, thank you for coming. You know what? This is such an important issue. And in the communities of colors, this is a paramount issue.
Indeed.
So what should we know, Dr. Llor, about colorectal cancer?
I think it's always good to start with good news. And the good news is that screening prevents lives. So it's really important to get screened. There are not that many screening tests in medicine in general that have shown such a strong evidence that screening results in saving lives. So if there is one big message here that I would like to give is get screened because screening does prevent cancer, colorectal cancer, and it saves lives. So that's just the most important message.
I like that. So how early what are we talking? Are we talking 20s? Are we talking 50, 70? What age is the ideal to get screened for this?
Sure. So for what we call average risk, meaning someone who does not have a family history, who otherwise feels fine, average risk right now is starting at age 45. That was recently lowered from 50 to 45, even though for African Americans, it had been recommended for a while to do 45. But now for everyone, an average risk recommended to start at 45. Higher than average risk would be having like a family member with who had colon cancer, particularly mothers, fathers, sisters, daughters, sons, first-degree relatives in general. If we have one of them who had colorectal cancer, then we need to be screened earlier. And that's usually 40 or 10 years earlier than when the age of the cancer was diagnosed. And of course, if the cancer was diagnosed early, like less than 50, genetic testing is called too, because sometimes we can find that this is due to a syndrome, something that's inherited, and that often presents with early onset colon cancers. In these cases, cancer genetics and genetic testing evaluation will be the way to go.
Wow. So we've learned a lot with genetic testing of finding out if we are predisposed to things. So do you suggest that should go hand in hand with getting tested?
So in general, what we say is that we just need to look at, so we're all different and we need to look at everyone's situation. If there's no cancer history, no significant cancer history in the family, not only colon, but other cancers, we can really, in these cases, we don't consider this a higher risk. So we would not indicate genetic testing in those cases, but certainly there's a family history of cancer, particularly younger individuals developing cancer. That's when really genetic testing should play a big role and should be. But again, that's always, the best thing is just to get cancer genetics evaluation, have that discussion, and with the pros and cons, and just go for it.
So what is colorectal cancer? Colorectal cancer, colon cancer, they're all, they're the same.
I think we've made great contributions to the confusion here. So sorry about that. But
no, that's fine. That's why we're talking, so we can eliminate confusion.
Absolutely. So Well, the good way to call it is colorectal because it's colon plus rectum. Rectum will be the beginning of the colon at the very end. That's what we call the rectum, something like 10 centimeters. And then as it goes up, the rest is called colon. But if we want to encompass the whole thing, we will call it colorectal. But sometimes to make it shorter, we say colon. But it's the same kind of like it's all colorectal cancer with some different specificities. But at the end of the day, really, the proper way to do it, colorectal cancer, that would be the proper way to call it. So it encompasses the entire length of the large bowel, which is what we're talking about.
Okay, so when we talk about this, because I think the most famous person that we know in recent memory is Chadwick Boseman, who was the Black Panther. He was 43 years old and fighting colon cancer. And it was a shock to everyone that he passed away. Can people survive this, Dr. Llor? Like, can people survive getting colon cancer?
Absolutely. I mean, there's been an incredible change in the survival for individuals who develop colon cancer. So there's been, I mean, there's been a dramatic improvement when it comes to treatment. So that is definitely a good thing. But obviously, if we can prevent it, that is the even better thing. And yeah, Chadwick's story really brought up to the attention how like very young people who often we don't suspect that they may have a cancer, they have it. And this, unfortunately, this is what we've been seeing over the last, I mentioned before that for African Americans, we've been recommending for a long time to start colorectal cancer screening at 45 and not 50. And that was because for the last 50 years, we had this higher incidence of younger individuals who are African Americans and develop colon cancer. So we've seen this for a while. But over the last 20 years, what we've been seeing is that the other groups, the Caucasians, the Hispanics, the risk of young onset colorectal cancer has gone up. And now it's similar in ages with the African American group. So basically, this is what's happening. We've seen this trend of younger and younger individuals developing colorectal cancer. And that's why guidelines last year and 2 years before that in 2018 started pushing in the direction of screening earlier, not only screening earlier, but also making sure that if there are any symptoms, some red blood in the stool, things like that, we don't overlook at it, even if the person is very young, because they can still have colorectal cancer. So we should be, our level of awareness has gone up because we do know that, yeah, more and more younger individuals are developing colon cancer. And historically, we've known that a big chunk of these younger individuals was due to those genetic defects that we talk about. But over the last few years, that's not the genetic defects that's been driving that increase. It's environmental. It's whatever it's happened. But basically, an entire generation, all the individuals that were born after 1960 or so, all those age groups have a higher risk of colorectal cancer than the generations that came before those. So,
do we know why?
Well,
or what do you guess? What do you think?
Sure. Yeah. So obviously, as we mentioned before, genetics don't change overnight. Genetic changes take hundreds of years. So we don't think that that's the explanation. The explanation has to be in what our environment is giving us, what we breathe, what we eat, what we are exposed to. Whatever that's been happening over the last few years that we've been exposed to has had an impact in that. And there are several things that we've known for a long time that are associated with colon cancer for everyone and also for the younger individuals, which is smoking clearly associated, lack of physical exercise, obesity, heavy drinking, all those have been associated with a higher risk. But all those do not explain that increase in the younger individuals. So it has to have, it has to do something with the environment that we are in. That really has been driving that increase in colorectal cancer in very, very young individuals.
So is this can women get colorectal cancer?
Exactly the same way. The incidence is lower, but still women can get colorectal cancer for sure.
Really? So primarily it's you see it in men?
No, not necessarily. It's higher in men, but definitely very high in women too. It's still for women the third most common cancer. And the third most common cause of cancer-related death in women. So still very, very common. So you have breast, you have lung, you have colon as the third one.
Wow. So so what are some of the symptoms? Because people will notice symptoms, Dr. Llor, and I'm sure you've come across this, and they'll see symptoms and they'll get afraid and they don't want to know and they won't go to the doctor. And then by the time they go to the doctor, it's damn near too late. So what do you say to those people? What are some of the symptoms? And what do you say to people about overcoming the fears if they discover a symptom to get themselves to a medical professional?
Yeah, I would start with the second, which is the sooner react, the more likely we're going to do well. That's clear. So I think that's why we should just not delay. When things are not right, we just should not delay, because it can make a huge difference that if we go now versus going a year later. That's number one. Symptoms. Some of them that really should worry us is having blood in the stool, or having belly pains that, they are unclear. They are not, we can put it together with like constipation or anything like that, or new onset constipation, for instance, a change in bowel habits, also changing the size of the stool, things like that, things that don't look right. Of course, like weight loss or tiredness, lack of appetite, all those things are also red flags. So all those things that are like make us feel that we're just not right there, we should not delay. So all those we really have to pay attention. And again, in the past, particularly for younger people, we said, if you have blood in the stool, maybe just hemorrhoids, and we just used to shrug, and it's like, that's it. Now we do know that we have to pay attention to that, because that could be a sign of colon cancer, and younger individuals can get colon cancer too. So we can't dismiss any of these, and we just have to get evaluated. And again, always the sooner the better, because that's when we can make a huge difference. The longer we wait, it's harder to make a big difference. Even though, again, as we were saying before, treatments have improved dramatically and people live for many years, even having been diagnosed with metastatic, with cancer in other areas of the body already yet. But boy, if we can pick it up early, the chances of doing well are excellent, really.
So let me just switch gears a little bit. So what is it like for the research around colon cancer and its reasons for it? I mean, do you read that information? I'm sure you do. Do you get that information about why? I know you said it's not genetics takes 100 years, so this is an environmental thing. But what does the research tell us about what we can do to sort of stave off or sort of eradicate colon cancer?
Right.
If that's a possibility.
Yeah. So definitely screening, as we said at the beginning, is the big thing, because it's made a huge impact. I mean, since we started more generalized screening in the 1980s, there's been such a steady decline in colorectal cancer that's been really a big success story. No question about it. Screening has made a huge impact. Therefore, we really need to emphasize that. And now that we are recommending to start at 45 for average risk, we need to make sure that, all these people who feel well, because many are very young, 45, 50, they need to be screened, because that's how we're going to make a huge difference. Then the other things that we're talking about, really having healthy life choices that makes huge differences. Like, for instance, no smoking, that is a big one. And regular physical exercise, that makes a big difference too, keeping an active life. There's data also on the association with red meat. So trying to go down with red meat consumption, that's also important too. And avoid obesity. Obesity has also been related to that. So trying to do all these things that are really, those are healthy. So those are healthy choices, no matter how we look at it, for our heart, for other reasons. They are also important when it comes to preventing colorectal cancer. And again, never forget the screening has made a huge difference in preventing colorectal cancer.
So what is the treatment like? So if someone finds themselves with the diagnosis of colon cancer, colorectal cancer, what is the treatment look like? And And how does the treatment look different now than it did, say, in the 80s? I'm sure there's been great strides made in terms of how we treat this.
Yeah. So the treatments vary depending a lot on the stage, which is like how advanced that cancer is. Early cancers are removed very often. Almost every day we find hundreds of early cancers removed endoscopically while they are patients are getting a colonoscopy. And in some cases, because the cancer was limited to an area of the polyp, of a large polyp that was totally removed, there's no even need for a surgery. So really removing early cancers, and that's how we prevent more advanced cancers, removing those very early cancers. So that could be a treatment on itself, not even a need for surgery. If there are more advanced cancers, then you may require surgery. If you have metastasis, meaning that the tumor has spread out to other areas, a common one would be the liver, then that usually includes treating the liver lesions plus the colon cancer with chemotherapy or lately immunotherapy, other different approaches. But it really depends a lot on the stage and if that cancer has spread out or it's still limited to the colon. Again, always the goal is trying to get it as early as possible because that's what less aggressively we can actually keep people healthy without even sometimes within surgery, because with the colonoscopy, we can just remove the whole thing.
So Dr. Llor, let's switch gears a little bit. So tell me a little bit, how did you come to medicine and how did you come to this particular type of cancer specifically? Like, how did you come to do what you do?
Well, that's a tough one. That is a tough one. I think that it's hard to think about how you come to medicine. There were no my brother did study medicine, but he was the only physician in the family. But probably he had some influence in the whole thing. And when it comes more into particularly colorectal cancer, I did start studying cancer genetics in the lab. And it felt very natural that if you've been studying a lot of things that have such a clear implication in patients, why not really doing the same at the patient level? So you have that communication between what your research interests are in a laboratory and really trying to translate it to the patient's well-being. That's, to me, that was a very natural and rewarding process, because sometimes the lab, it's very hard to connect lab work and patient care. So that's what really got me connected. So it started more from my research interest, and it's like, okay, well, with that research, how can I make a difference? And then it becomes very natural. It's like, that's what I want to do, to make sure that whatever I learn in the lab applies to patients, and it's not something that may or may not apply in years. So let's just make it happen. That's what got me excited.
Oh, okay. All right. And I mean, you hold a lot of titles. You hold a lot of titles at the hospital and at the Smilow Cancer Hospital, which I think are probably kind of one and the same a little bit. So you are the director of Smilow Cancer Genetics and Prevention Program. Talk a little bit about the importance or what role genetics plays and how we sort of address healthcare moving forward.
Sure. So genetics, from the standpoint of genetic defects that we inherit from our parents, and some of them happen, new ones, and their effect in cancer, they don't affect a huge number of individuals, but the ones that do, which is usually in between 5 and 10%, those have a very important influence there when it comes to risk, because the risk is increased dramatically, but also because we may have different types of cancers that go together with those genetic defects, and also response to treatment. Chemotherapy treatments are starting to be targeted or tailored to individuals who do have those mutations. So it's become very, very important to diagnose these genetic defects not only to prevent cancers, because when we know of someone who has that defect, we can start doing surveillance and apply measures that will decrease the risk of cancer in these individuals, or at least catch it early enough. So that'd be very important, but also it has an influence in the treatments that we may be getting if we were to develop cancer and all that. So the role has become much more important now that we know much more about it. And certainly, again, if we do have any level of suspicion that a patient could have a syndrome, certainly needs to have genetic testing that's very widely available nowadays. And that really guides us in all these different aspects of the care. And also, if anyone is diagnosed with a genetic defect like this, the other family members can get tested, and they can also benefit. If they are test positive, they can benefit from these surveillance measures. And if they test negative, yet the other family member is positive, then we know that person is negative. So that person will have average risk of cancer. So we don't need to target everyone in the family. We can only target the ones who actually inherit the mutation. So as usual, knowledge is power, and particularly in this case, that is true. It can make a huge difference knowing. So that's why it's so important. So again, it's not for the largest percentage of individuals, but for a small group, it makes a huge difference.
I think the first time I've ever heard of that kind of genetic testing is with breast cancer, right? When women get tested, and if their mother had it or their grandmother have it, they want to know if they're in line for it, and then they can make some decisions about what to do to move forward. So that has been in our recent consciousness around genetic testing and understanding how disease can pass from family members to family members.
Yeah, it's the same story with colorectal cancer. While for breast, it's BRCA, BRCA, the BRCA gene. Now we know about several other ones, but BRCA were really the ones we've known for a long time, the ones that are more common ones. But also we learned that there's something very similar with colon and endometrial cancer with this Lynch syndrome, which is also similar in terms of how common it is. And again, it also allows us, as you mentioned, with the breast cancer, the same thing with when we are diagnosed with Lynch syndrome, which can institute endoscopies and screening for endometrial and ovarian cancer, because there's also a higher risk of all those cancers too. So all those things can be implemented in individuals who have this higher risk of a colon cancer syndrome. And it's in the same way as BRCA and for breast cancer. So very, very helpful, and clearly shown that it does save lives. So that's why it's so important. Whoever there's any suspicion that anyone can have a syndrome like this should be tested, so we know what to do.
So you're also the Associate Director for Cancer Screening, Community Engagement, and Health Equity. And since the pandemic, we have learned a great deal about community engagement and health equity. And the pandemic has really put a spotlight on health inequities in communities across the world. Talk a little bit about what you do in terms of health equity and community engagement, and how important that is, particularly around colorectal cancer.
Sure. Well, first, the facts. The facts is that, as you said, the pandemic has pointed it out. It's not that we have not known about inequities in healthcare in the U.S. for the longest time. I mean, I don't know how many more times we need to document that. What we need to do is to make it disappear. That's what we need to focus on, because we know it's been happening for the longest time, and that's been a true disaster. So now what we want is to focus on, tackle this and making sure it doesn't happen. There are clear things. We do have, if we think about screening rates, we have communities that have lower screening rates. African Americans do have lower screening rates, and yet they have higher colorectal cancers. So that's important. The Hispanic population in Connecticut is also very underscreened. That's important too. And one of the most determinant factors about who's getting screened and who's not is really the type of health insurance we have. And from very high levels of screening with Medicare patients to very low levels in Medicaid patients or patients who do not have health insurance. So we need to tackle this. We need to specifically and figure out how to better screen the individuals who are like falling or we are not appropriately screening. So how we do that? Several things. One of them is we've engaged with the community health centers in our area and try to see how we can actually help in increasing the screening rates, not only through availability of screening choices, but also helping figure out what the best choices for screening are. Because in the US, we've heavily based our screening for colon cancer on colonoscopies. And often we have not considered other choices, which are basically stool-based, and they are all good choices to start with. And a lot of individuals do have a hard time having to go for a colonoscopy because that requires a full day off of work, preparation the day before, someone to go with them. And so we often, as physicians, we said, you're due for a colonoscopy for colon cancer screening. And we did not have a discussion with our patients. We did not consider that people may have a harder time getting someone to go with them or having a day off from work. We need to understand all these things, have that conversation with the patients. If it's easier for some patients to have a stool-based test and they're comfortable with that, let's help with that too. We need to we need to increase the dialogue so we understand better what's going to work best for everyone. And we have to do this with everyone so we actually get our screening levels up. And so we can no longer be blinded to the fact that everyone has circumstances, and we have to try to help and try to meet everyone where they are in terms of what the needs are. Trying also to working with some volunteer organizations about chaperones, for instance, and people who don't have anyone to go with them for a colonoscopy, to see if we can get someone who would just volunteer to go with them because they get sedation and people can go without someone going with them. So we've put a lot of barriers in healthcare, and we just need to go one by one, trying to tackle them and trying to figure out how we decrease those barriers. And the first one is really having that frank conversation with one-to-one with every single patient and see what's possible and how we can actually handle every particular situation, because there's no one size fits all, and barriers are different from one person to another. And this is what we really need to do. We really need to tackle every single barrier for everyone so things can happen. And screening is so important that we need to make it happen. And we just need to tackle every barrier. So that's what really we want to focus on. Make sure that everyone does get screening. There are other things like perceptions also. Everyone has perceptions about what screening is and the methods and all that. Well, again, having frank conversations and community leaders and community champions to really help us bridge the gap of communication. That's also very important and something we're very interested in partnering. Meaning, I think it is all about partnering with community champions who really want to improve the health of the community where they live. So we can all, feel that we're all on the same page, and not in a prescriptive way, but actually in a partnership kind of way. So things happen in a way that everyone is comfortable and everyone understands that that's important.
Wow, that's pretty impressive. I think that's the right idea. I think meeting people where they are, particularly at the community level, I think that's the way to go. I think historically, people had to go to their doctors, be intimidated by their doctors, and then just what, I don't understand what he's saying. I don't understand the language. I don't understand any of this. And I can't take any time off from work. But if you get them at the community level, at the community clinic level, then you might have a better chance of making some real inroads. At least that's how it looks to me when I look out and see, the community centers opening up and seeing the centers in communities in ways that I haven't seen when I was a little kid. I think that's pretty important. So everyone, average person, I know I had my colonoscopy when I was 50.
Mm-hmm.
I'll be 60 next year. So I think it's a 10-year.
Everything is fine, 10 years.
I feel like, man, I just had it. So I got to go back and do the whole thing all over again and get it done.
Uh-huh.
But I'm happy to do it because I think that's part of having access to health insurance to take part in all the things. So if you could sum up for the folks who are listening, like
Mhm.
as they think about March being colorectal prevention month, what would you charge them with doing after we leave this show today? What do you want them to do?
I would just ask them to just, make an appointment and have a conversation with your provider. That's all. It's like, I've heard that. I hear it's important. Can we just have that conversation? And how can we get screened and how we can get things going? Just have that conversation. Often it's just that lack of conversation. And we empower ourselves when we really engage in a conversation. And I think that's what we need to do. And if the doctor is not doing it, what the heck, let's just push the doctor to have it.
That's a good idea. That's a good, and it's not I mean, I know it could be scary for people. Any kind of conversation around cancer
Yeah.
is scary, right? Because people just think it's going to be their death sentence.
Yeah.
But we have to sort of move people away from being so afraid. And so your suggestion is to have the conversation.
Exactly. Have the conversation and always remember catching cancers early makes a huge difference. And that's what we want to do, like catch them as early as possible or even prevent them if we can, because things are so much easier if we can do that early. So I think we just, our tendency is like trying to ignore when we see a potential problem, but it's like we have to turn it around and say, if we act early, that potential problem is not going to be a problem. And I think that's how we should look at it.
Mm. So before I let you go, Dr. Llor, what's the best part of your day?
I do a lot of things in a given day. I think the most rewarding part is always when you have those conversations with patients and you feel that you have made a difference, which doesn't happen every time, because it can be for a lot of things. Many times you just don't know how to do it. But when that happens, when you feel, boy, I made a difference, that's what's going to be my day for sure.
Mm. Thank you so much for spending this time with me. I feel like I learned a great deal. I feel like I feel confident when I make my next appointment for my colonoscopy. and I will have a conversation with my doctor like, okay, is there some alternatives to this? I mean, I'm happy to have the colonoscopy. I don't have the same barriers as most people have, but I will raise the matter just to have the conversation, so that I feel like I'm doing my part and that I've learned something from you today.
And in doing so, probably you'll have that provider to talk to other people and have that conversation.
Yes. Well, thank you so much.
Thank you.
And I so appreciate that. Oh, someone had a question in the chat room before I let you go, and it just
Sure.
popped up. I don't know if you feel
Sure.
like you want to answer a question.
I'm fine.
I think this woman is Joanna Varner. And she wanted to know why aren't doctors doing the research on the THC in brain tumors? She's a caregiver and has seen fully extracted cannabis oil. Oh yeah, because there's this whole movement of folks who believe cannabis can be a part of a lot of treatments, particularly around chemotherapies and that kind of stuff, sort of help people through things. I mean, do you have some thoughts on that?
Not sure how to apply this to this. I know that cannabis is applied for pain purposes and all those things, but really I'm not sure how to respond to this because I'm not sure I understand the actual question.
Yeah, I'm not understanding I mean, it's more like a statement, but
okay.
Anyway. But thank you, Joanna. I'm going to let the good doctor go.
Thank you very
I so
much.
Appreciate you, Dr. Llor, for coming on, and feel free to come back on again, so that we can continue to raise awareness around screening for colorectal cancers.
Sounds good to me.
Thank you so much. Have
Thank
a
you.
good day.
You too. Bye-bye.
Bye-bye. Woo, Harry, that was a good conversation. Although that question threw me off because I don't think it's a question so much as it is a statement.
Yeah, THC.
And that's not what we're talking about. I think
Patients. Chemo is too big of a particle to break through the.
Yeah, I think she needs to talk to a different doctor. I don't know. I just feel like, so I felt like I wanted to ask, put it out there because you popped it in, but no. Thank you, Joanna. I think you have to,
Yeah, I mean, I understand. I've been listening to a lot of the, the cannabinoid stuff and everything, and it sounds very promising, but also complex. Then maybe it's gonna be there will be a time where that type of medicine or therapy will be used more often, but I don't think they know enough about it yet.
Yeah. Well, it was really good to have the doctor on.
Yep.
And
need to go get my screening.
Yes, Harry, I gotta go. Listen, I'm due next year. I'm gonna do it because you know what? I want to live long and prosper.
Yeah, I got mine about over 5 years ago, probably like 6 years ago. I'm supposed to get it every 5 years because my mother and father had colon cancer. So yeah, I have to.
Oh yeah, so you gotta get screened on the quite often. Every 3 years, every 2 years.
Every 3 to 5 years they say, but I'm already at 6. I'm behind. I gotta go.
Okay, listen, Harry. Listen, we just had a whole doctor on talking about this. You can cure these cancers, if you go get tested. I mean, Chadwick Boseman was 43 damn years old. Come on. Go, you get off this phone today and you go make an appointment.
Yeah, my sister just got her screening and she was getting on me on text.
Yeah. Because if they find something while they're doing a colonoscopy, they could deal with it right then and there.
Yeah.
So, all right, Harry, don't make me. Listen, you better call today. I'm not playing with you because I will every day. This will be the conversation. We'll spend 2 hours talking about this. If I have to have Dr. Llor on every damn day from now until you get it done.
Anyway, we gotta go.
Gotta go.
Look at the way you looking at me, Baz. What's wrong with you?
Because you need to take this serious. Like, don't be playing.
I know. On me. But I will get it done soon.
All right. No, not soon. Call today. Make the appointment. Call today. Don't be playing, Harry. I'm telling you. All right. You got 3 granddaughters that need their papa. You got a wife that does not wish to be a widow. So just. And your mother does not want to bury another child. There you go.
Like me yesterday, you don't want to get off, Babz. We gotta go.
I'm getting off. Bye.
Have a wonderful weekend. See
you
Monday.
Too. Enjoy your trip to Orange. Get your Jamaican food. Maybe I'll run into you.
All right. Oh, wrong one.
Mm-hmm.